All right, thanks, Tricia. And I appreciate all of you people out there joining us for the UCLA Esophageal Insights Zoom series. I certainly hope it's worth your while. We're going to talk about impedance tonight. And as I say when I present this topic, don't worry, be happy. So, esophageal impedance testing. This is what we're going to do. We're going to talk about using impedance to measure bolus transit in the esophagus, to measure the mechanical properties of the esophageal wall, and to measure motor function of the esophagus. So those are the three areas that we're going to endeavor to understand better tonight. So this is probably the scary part. What is electrical impedance? Well, it's the opposition that a circuit presents to a current when a voltage is applied to that circuit. For us, as gastroenterologists, it's the opposition that the tubular organ, the esophagus, and its contents present to a current when a voltage is applied. Impedance for the purposes of this talk are going to be analogous to electrical resistance because electrical resistance is easier to understand than impedance. But they're about the same kind of thing. So this, most of you are probably familiar with. This is an impedance pH catheter. There is a pH sensor located 5 centimeters above the esophagogastric junction. And then there are pairs of recording excitatory and detection electrodes that are spaced along the catheter in the distal esophagus and more proximal esophagus as well, so that we record impedance events from 3, 5, 7, 9, 15, and 17 centimeters from the esophagogastric junction. This is a typical catheter, but the configurations can be somewhat different from manufacturer to manufacturer. Notice that these sensors, these electrodes are free in the lumen of the esophagus. They're not enclosed by anything, and that's important in understanding what we're going to be looking at. So when you measure luminal impedance, a small constant AC voltage is applied across electrodes on the impedance probe. This generates a small current that we can measure. And since we have a constant voltage and we can measure the current according to Ohm's law, then we can calculate the impedance or the resistance. So simple equation, it's just Ohm's law. According to this simplification of Ohm's law, since the voltage is constant, a change in current, which we record, will be reflected as a change in impedance. So that a decrease in recorded current is seen as an increase in impedance, and an increase in current is seen as a decrease in impedance. Now we have to remember that we can see the bolus in the esophagus because the impedance in a bolus that's either swallowed or refluxed is usually quite a bit lower impedance than the wall of the esophagus. So the other important thing here is impedance of air is very high. So it's seen as a very large spike on the impedance recording. And we're going to talk about how this can be useful diagnostically as we move through the talk. The impedance of the organ wall, the esophageal wall, is 10 to 30 times higher than the impedance of what's being the bolus that's being moved either up or down the esophagus. There's a low impedance in the bolus, which has high ionic content, which makes it easily distinguishable from the surrounding environment and the wall of the esophagus. So what determines the impedance measurement? It's three things: the ionic content of the material surrounding the electrodes, and in this case, with refluxed or swallowed materials, varies the cross-sectional area of the lumen. So the larger the cross-sectional area of the lumen, the greater the current and the lower the impedance. And then finally, part of that impedance measurement comes from the esophageal wall. So this is not a quantitative test for two reasons. There's variability in the ionic content of the bolus, and we are measuring impedance not only of the bolus, but the esophageal wall. So how does impedance change? Well, when the organ is empty and relaxed, the impedance is high. And when when the organ contains a bolus, which has ionic content and expands the lumen, the impedance is low. So, as the bolus moves along, ahead of it, the impedance is relatively high. In the bolus, as it's moving along, the organ expands and is full, so the impedance is low. And then when the organ contracts to propel the bolus, the impedance is once again high. So we're looking for low impedance events to be reflux events or swallow events. And the direction of their movement can distinguish one from the other. So this is a study that was done now quite a while ago, and one of the initial studies on validating impedance. What you're looking at here is a video swallow, and this is the barium in the esophagus. The blue arrows represent the location of impedance electrodes, and this line and this yellow dot are the impedance tracing. So before the bolus reaches the impedance electrodes, impedance is high. When the bolus begins to make contact with the first electrode, the impedance starts to drop. When it contacts both electrodes and stays in contact with the electrodes, we're at our low point in the impedance. And then as the bolus passes, losing contact with this upper electrode, the impedance starts to go back up and then goes back to baseline when the bolus has lost contact with both of the electrodes. So if you look at an impedance tracing, and probably many of you have, this is sort of the ideal study. Doesn't always look this pretty. Here's the location of the impedance that is recorded from the esophageal gastric junction up. This channel is pH, and here is the impedance event. So there's a reflux event here, and a reflux event by the impedance method is defined as a 50% drop in impedance in less than 2 seconds and remaining for greater than 3 seconds. So you look for a 50% drop. That's right here. So that's the event in the most distal esophagus. Here is the acid reflux event. That is, the pH is dropping below 4. And you can see that it coincides pretty well with the beginning of the impedance event. All right. And this, you can see the impedance moves up the esophagus in time. And this is the highest point of the refluxate. So we didn't record any higher than 17 centimeters. So this is a proximal reflux event. And this is what we look for when we're looking for reflux in the esophagus. Sometimes there is not an associated drop in pH. So that would be either a non-acid reflux event or a weakly acid reflux event. Now, recently, there's been a lot of interest in using the impedance method to identify other boluses in the esophagus. The most recent is the belch. And remember that I said air causes a marked increase in impedance. And this is what you're seeing here. So there's an impedance event that moves up, high impedance event that moves up the esophagus over time. And it's lost over time as well. So this is air moving up the esophagus, and that is a gastric belch. So this would be manometrically associated with a transient lower esophageal sphincter relaxation. The supragastric belch is quite different. In a supragastric belch, the high impedance moves down the esophagus, so air is moving down the esophagus. This happens when someone either pushes the air down from their pharynx, or the upper sphincter opens and the diaphragm contracts, producing a marked decrease in pressure. And that marked decrease in thoracic pressure leads to air going into the esophagus. And then this is the air being expelled back out from the esophagus. So I'm sure we've all seen these people. They're a little bit difficult to manage, but we can use this technology to help us sort out whether belching is gastric belching or supragastric belching, because their treatments are quite different. This you might try to treat with baclofen. This we treat primarily with a sort of a biofeedback technique. So that's impedance pH testing. We also have impedance manometry that we use. This is an impedance manometry catheter. These copper colors are pressure sensors, and actually each of these has 12 circumferentially arranged pressure sensors. There are 36 of these pressure sensors. They are located 1 centimeter apart on center, and that makes the operating length of this catheter 35 centimeters. It's long enough to span from the stomach to the pharynx, so through both the lower and upper esophageal sphincters. The gold-colored rings are the impedance electrodes. And you can see that they're also spaced along the length of the catheter. Just a reminder, with high-resolution esophageal manometry, This band of color, color is pressure. Here's the relationship between color and pressure. This is distance from the nares, and this is time on this axis. This band of warmer color is the upper sphincter. Down here is the esophagogastric junction, and in this case, the lower esophageal sphincter. This drop in pressure here is opening of the upper sphincter. Here's peristalsis in the pharynx. This drop in pressure here is opening of the esophagogastric junction. And this is a typical peristaltic sequence. The higher pressures here are generated in the strided muscle esophagus. The higher pressures here are generated in the smooth muscle esophagus. And this is the transition zone where the pressure generated by contraction drops off and sometimes is absent. This zone is where the muscle is moving or changing from a strided muscle to a smooth muscle. So it's called a transition zone where the muscle is mixed. Okay, just a little reminder about the manometry. Look right here at this line. Notice that the pressure goes up just a little bit from a darker blue to a lighter blue in here. And this is actually the pressure caused by the bolus in the esophagus. And notice that the pressure here is once again lower than in here. So with the manometry, we can tell that the bolus has entered the esophagus and has been cleared from the esophagus. Having said that, impedance makes it significantly easier to see if the bolus has cleared. The magenta that you see here is the low impedance in a saline bolus that has been swallowed. And you can see it looks a lot like the image I just showed you where there's a straight line. The bolus is here and the magenta is not here. That means that it's been cleared from the esophagus. Sometimes in normal individuals, we see a little bit of this bolus hang up in the proximal esophagus. That's called bolus escape, and it's relatively common. This is the impedance in the stomach. It's not because the stomach is full, it's because the stomach is a secretory organ. So there is ionic movement across the epithelium. And when there's ionic movement across the epithelium or the mucosa, it is detected as a low impedance. There are a few other things that can produce low impedance in the resting esophagus when there's no swallowing. Those things are stasis, like in achalasia, esophagitis, and the reason that it happens in esophagitis is there's ionic movement across the usually tight squamous epithelium. Eosinophilic esophagitis also has a lower resting impedance, and Barrett esophagus has a lower resting impedance. So the four things we think about are esophagitis, eosinophilic esophagitis, stasis, and Barrett esophagus. So this is a quick case to show you how this technology might be used, the impedance might be used to help make a diagnosis. This patient was a college student with regurgitation. If you look carefully here, you'll see that right here is the esophagogastric junction. This is a valsalva. So this is the pressure in the stomach. And the pressure wave is moving up the esophagus over time. See how this line is sloped. The upper sphincter opens. So this is a distinct image that would suggest the patient has rumination syndrome. The impedance really helps us with that. It shows that a bolus is moving from the stomach up into the esophagus. And then with a peristaltic wave, it's pushed back down into the stomach. So this is what we see when we have a patient with rumination syndrome. We actually feed them something during the manometry, and then we have them wait in the manometry room with the catheter in place, and we give them 15 to 30 minutes after eating to see if this pattern occurs. This is a patient who had a gastric bypass who was suffering mightily from heartburn and regurgitation. There are several interesting things here. Here's the esophagogastric junction. Here's the upper esophageal sphincter. There is the peristalsis in the pharynx. What you notice here is that there is peristalsis here and here, but they're not associated with opening of the upper esophageal sphincter or peristalsis in the pharynx. So when we see this, this is called secondary peristalsis, and it occurs because there is a bolus in the esophagus, and it's a reflex attempt of the esophagus to clear the bolus. So the impedance helps us with this one. You can see that the patient swallows and things clear. Even with the secondary peristalsis, most of the bolus clears, but almost immediately after the bolus is cleared, it refluxes back up into the esophagus. So this patient was having symptoms of heartburn and regurgitation because she was having just free reflux up into the esophagus. And it's obvious with impedance. So now let's move to the hot topic these days. It's called endoflip, or functional luminal imaging, but its real name is impedance planimetry. So what is impedance planimetry? And we'll go through what this is. This is an impedance probe. It's one of the original ones from the 1990s. It's actually been cut in half and offset just a little bit for ease of seeing what's going on. So here's the probe. There is a bag on the probe that is what's called infinitely compliant. So the infinitely compliant balloon encloses both excitation and detection electrodes. And there are 2 of each on this original version. The balloon can be filled with varying volumes of liquid with a known conductivity. So that means it can conduct electricity. These lines, dotted lines, are the electrical field lines. So this is the electrical current moving from this excitation electrode to this one. And then finally, in this balloon, there's a pressure sensor on the probe within the bag or the balloon. So that's the original device. So what does impedance planimetry tells us? Well, it allows us to simultaneously measure cross-sectional area of the esophageal lumen and pressure generated by the esophageal wall, so usually contraction. So a bit of history. These guys turn out to be friends of mine. Hans Gregerson was the inventor of this device in the 1990s. He was on sabbatical at the University of Iowa, where he worked with Satish Rao. And they were the first to use this methodology to quantify esophageal wall distensibility. So it's been around for quite a while. I got in the act with Satish in the early 2000s, just before the time I left the University of Iowa. And we used the impedance planimetry to help us better understand sensation and sensory perception in the esophagus. And then McMahon in 2004 was the first to use the device for esophagogastric junction distensibility, and it's one of the major uses even today. So, what is an infinitely compliant balloon, and why is it needed? All right, so this axis, we're looking at volume. This axis, we're looking at pressure. So as in a latex balloon, sort of like a party balloon, you know that as you blow that balloon up, the pressure inside the balloon increases. That's why when you let it go, it shoots all over the place. So here are the volume, pressure, or compliance properties of a latex balloon. As the volume is added, the pressure goes up. We don't want that to happen with this technique, because when this kind of compliance means that we will be recording pressure caused by the esophageal wall as well as the balloon, and it's nearly impossible to distinguish them for several reasons. Now, this is that compliance relationship with the flip balloon or the impedance planimetry balloon. The material, I tell people, is very much like that of a sandwich bag. And if you think of blowing up a sandwich bag, you'll understand what an infinitely compliant balloon is. As the volume is increased in this balloon or bag, the pressure changes very little until the bag is completely full. And at that point, applying more, trying to fill the balloon more, leads to a rapid increase in pressure. The advantage of this balloon is if we continue to operate in the lower volume range here, any pressure that is measured in the balloon is from the biomechanical properties of the wall of the esophagus. That could be the elasticity, or it could be contraction. So pressure in the balloon is only that generated by the esophageal wall. Very important for this flip technology. All right, back to Ohm's law. Remember, electrical impedance is the opposition that a circuit presents to a current when a voltage is applied. Here's our simple circuit with the voltage, the current, and a resistance. And remember that resistance or impedance can be calculated from the voltage in the current, or in the circuit, and the current. So in this case, if we hold the current constant and measure voltage, we can calculate then impedance or resistance. So another image of one of those early impedance sensing devices. There's this balloon. The balloon is filled with saline. There's an excitatory electrode here and here. And remember, in that first image I showed you the current lines going from one to the other. These two electrodes are detection electrodes, so they measure the voltage. And there's a pressure sensor right between those two things. So again, Ohm's law. And now, if we know the impedance, this is the distance between electrodes, we can calculate the cross-sectional area of the balloons. D is the distance between the electrodes, and CSA is cross-sectional area. So now we have a clear and precise relationship of impedance to cross-sectional area. That brings us to the functional luminal imaging probe, or FLIP. This is a picture of the balloon. Here's a schematic. The catheter is 3 millimeters wide. There is an 18 centimeter infinitely compliant balloon on the catheter. That's what this guy is. The volume in that balloon is 70 mLs. And there are 16 impedance electrodes spaced at 1 centimeter intervals. There's a pressure transducer at or sensor at the distal end within the balloon. And there's an infusion port so that varying volumes of saline can be infused into the balloon. So when you do this study, this is a little bit of a simplification. Saline is infused, and as the saline is infused, the esophagogastric junction is detected as a waste on the FLIP profile. So here we go, right here. So we can see the waste. This arrow indicates the lowest cross-sectional area in this waste. So we infuse in 10 cc increments from 40 cc's to 70 cc's. And at each volume, the balloon pressure and narrowest cross-sectional area are determined. And then the distensibility index at this point is calculated. So what is that distensibility index? Well, here it is. Here's our image. This is the smallest cross-sectional area, where the smallest cross-sectional area is. And this equation, you've seen, this is cross-sectional area divided by pressure, which is in this case called the distensibility index. Its other name is compliance. So the normal for the esophageal gastric junction distensibility index is greater than 2.8 millimeters squared per millimeter mercury of pressure. All right, so that's we're going to call this DI. Here is something you're probably pretty familiar with. This is measurement of the integrated relaxation pressure or residual pressure at the esophagogastric junction. We don't need to go into how that is derived, but normal is less than 15 millimeters of mercury. Now, this perhaps is the worst metric in the Chicago classification. We see lots of people who have normal esophageal function and an minimally or mildly elevated residual pressure at the EG junction. And the question then always becomes, is that a real thing or not? And we actually did a study where we took all of our patients with an elevated IRP, and we did either endoscopic ultrasound or CT of the chest in all those patients. And the vast majority had no finding that would explain why the IRP was elevated. Now recall that the IRP is a measure of resistance to flow across the esophagogastric junction. So an illustrative case in how this impedance technology might be useful. Our patient is a 58-year-old woman with dysphagia. She has a 1-year history of dysphagia to solids and liquids. Her ANA is 1 to 640. Her anti-centromere is 1 to 640, but her anti-SCL 70 is negative. So we have the centromere antibody suggesting she has scleroderma and the SCL 70 not. However, she does have Raynaud's phenomenon, but no calcinosis, sclerodactyly, or this should be telangiectasias. So it's a little befuddling. Is this a case of dysphagia because the patient has scleroderma and the esophagus doesn't work? Well, let's find out. So the workup then, she had an endoscopy, and the esophagogastric junction was normal. There's no stricture here, and you can see in the retroflex view, it's also normal. Maybe just a tad loose, but probably normal. Here is her barium swallow. And you can see that the esophagogastric junction here opens up, but it's just a little narrowed. And the radiologist said, it's just a little too narrow, not quite right. And also there's essentially no motor function in a slightly dilated smooth muscle esophagus. And then here is her esophageal manometry. So for all the world, this looks to me like Achalasia Type 2. There's no peristalsis, simultaneous pressure waves, and the esophagogastric junction is not opening adequate. The integrated residual pressure was 23.8. So now we're here with a little bit of conflicting data. There's some of this that looks like clear achalasia. There's some of it that looks like maybe not, at least anatomically and radiographically, it might not be achalasia. So what did we do? We did the endoflip, right? So this image is the balloon volume 60 mLs and the EGJ-Distensibility Index, this spot right here, right at the narrowest spot, is 0.8 millimeters squared per millimeter of mercury, which is too low. So this is abnormal. She did not have a stricture. and she has no peristalsis. So we said this looks compatible with overall with achalasia. The patient was sent for a POEM procedure, and she's done very well following the POEM. Things have improved dramatically. Her dysphagia is much better. There are other things you can use this impedance method for. They are identifying successful or failed myotomy, be that from a Heller myotomy or POEM. It's also useful in the situation of a fundoplication that might be too tight. All right, so FLIP can also be used to evaluate esophageal function. Remember, we have a lot of impedance electrodes sitting above the esophagogastric junction. So maybe we can see what the esophagus is doing as well as the esophagogastric junction. Again, a reminder, this is normal peristalsis. And this I'm showing you for reasons that have to do with the FLIP technique. So this is a swallow. Here is peristalsis in the striated muscle esophagus, but in the smooth muscle esophagus, it failed. And you can see that the pressure is higher here than over here. So that tells us that there's a bolus in here, and here is a peristaltic sequence that's occurring in the absence of opening of the upper esophageal sphincter or pharyngeal peristalsis. So this is called secondary peristalsis. And much of the contractile activity identified with the FLIP technology is secondary peristalsis. It is the response of the esophagus to stretching the wall and increasing the pressure. So a little terminology before we launch completely into this. This is diameter of the esophageal lumen and the balloon. You can see that narrow diameters are black and red. More open diameters are blue. Okay. So the catheter and balloon have been placed in the esophagus. Here's the esophagogastric junction, which is opening. And these narrowings of the diameter of the esophagus are what are called repetitive antegrade contractions, or RACs. This is secondary peristalsis over and over again when the balloon is distended. This is normal. Here we have absent contractility. Nothing is happening. Here, there's just a hint that there's some contractile activity, but no real retrograde or antegrade contractile activity. And then last, here are contractions moving the wrong direction in the esophagus from the esophagogastric junction up. These are called repetitive retrograde contractions, or RRCs. So these are the players, and these are used to make diagnoses of esophageal motor abnormalities. So a normal flip topography is seen here. Time is running along the axis down here. The blue line is stepwise increases in volume. The red line is pressure in the probe. Okay. Once again, here's diameter, which you have seen, right, previously. This is before the procedure really is started. This is a collapsed and narrow esophagus in the 3D mode. As you can see, as the balloon is distended, these antegrade contractions start. And here is the esophagogastric junction. It begins to open. Right? Now, this is at these 3 time points. This is this one wave of decreased diameter. And you can see that it moves down the esophagus over time. So this is peristalsis. And then this is, as the volume increases, the esophagogastric junction stays open and the racks stop. So this is what it should look like. This is normal. So let's look at the types of achalasia. This is manometry. No peristalsis in the smooth muscle esophagus and no opening of the esophagogastric junction. So this is achalasia type 1. Here is the flip recording from this patient. Here is the volume in the catheter or the balloon being increased over time. Time is running along this axis, and this is pressure. And as an aside, to do the flip analysis correctly, the pressure in the balloon has to be at least 15 millimeters of mercury. So what are we looking at here? As the volume increases, we're not seeing any contractile activity, which is abnormal, and we're not seeing the esophagogastric junction opening. That is, the distensibility index is too low. So this is what type 1 achalasia looks like. Here's type 2 achalasia with high resolution manometry. So here's opening of the upper sphincter, panesophageal pressurization. The pressure is the same all up and down the esophagus, and incomplete opening of the esophagogastric junction. So this is the flip, and what you're seeing is there's a combination of both antegrade and retrograde contractile activity, but it appears to be weak. This is abnormal. These are always abnormal. And here is the esophagogastric junction that is not opening as the volume in the balloon is increased. So again, normal, and the distensibility index in this case is also going to be very low. Then achalasia type 3. For the manometry, It is failure of peristalsis with this high amplitude contraction and failure of opening of the esophagogastric junction, so a high IRP. And this is the flip pattern. There are repetitive retrograde contractions, and once again, no opening of the esophagogastric junction. The pressure is going to be high, and the distensibility index is again too low. And then finally, this is the a place that the flip really helps us. It's in those cases where the integrated residual pressure is too high, above 15 millimeters of mercury. Here are 3 cases. The first one, the distal latency, that's the time from opening of the upper sphincter to arrival of the pressure wave at the esophagogastric junction, is normal. Should be greater than 4.5 seconds. And the integrated residual pressure is too high, greater than 15 millimeters of mercury. When we look at the flip, we see that the distensibility index is much less than 2.8. So abnormal distensibility, suggesting that this might be some variation on the theme of achalasia. Here is another case. There is peristalsis here. The distal latency is normal, and the integrated residual pressure is too high. Again, we look at the flip, we see abnormal contractile activity. That is, there are repetitive retrograde contractions. And once again, the esophagogastric junction here does not open adequately, and the DI is 0.26, which is too low. So this is the real thing. This is perhaps some variation on achalasia as well, although there is normal peristalsis. Then here's the final case. The distal latency is normal. The integrated residual pressure, once again, is too high, greater than 15 millimeters mercury. And now, when we do the flip procedure, we see here's the esophagogastric junction. You can see that it's turning blue when there are these decreases, propagated decreases in diameter. So this is peristalsis, and this is opening of the esophagogastric junction associated with the peristaltic sequence. And the DI here is 7.93, which is normal. So this IRP was probably not correctly identified by the manometry, and the patient appears to be normal. So all of this has led to attempts at classification schemes for flip. It looks a lot like the Chicago classification. If you are, I don't think I'm going to go through this all in great detail. It will be, well, maybe I should. So we start, as in the Chicago classification, with the esophagogastric junction, and we're looking at the DI. If it is abnormal, then we look for RRCs and RACs. If there are RRCs, then you most likely have a spastic achalasia. If there are no RRCs, then you look for these contractility plus or minus RACs. If the answer is no, it's achalasia without contractile activity in the esophagus. And then if you have RACs, the answer is yes. So normal antegrade contractions, this represents EGJ outflow obstruction, which may be a variant of achalasia or subtle mechanical obstruction. So these are the disorders with EGJ outflow obstruction. If the DI is normal and there are RRCs plus or minus RACs, you have a spastic motor disorder. If there are neither RRCs or RACs, right here, no RACs, answer is no, then you have absent contractility. If you have RACs, then if the answer is no, you have diminished contractility. If the answer is yes, there are RACs, you have normal motility. So this is normal. So it's going to, I'm sure that this is going to be adjusted and modified over time as people understand more and more about this technology and the way the esophagus responds to the technology. So finally, there are some AGA clinical practice guidelines. The AGA says that clinicians should not make a diagnosis or treatment decision based on FLIP assessment alone. They say that FLIP assessment is a complementary tool to assess EGJ opening dynamics and stiffness of the esophageal wall. Its utilization should follow distinct protocols and analysis paradigms based on the disease state of interest, and that is being done. Clinicians should not utilize FLIP in routine diagnostic assessments of GERD. That makes sense. It's not a way to measure GERD. And the FLIP should not be used to diagnose eosinophilic esophagitis, but there are situations where FLIP may be beneficial in assessing the severity of the disorder and therapeutic monitoring. That is, are you decreasing the stiffness of the wall of the esophagus with your therapy? So thank you. This is the link to our Esophageal Center website. If there are any questions, I'm happy to answer them. Thanks.